in Oxford. It is designed around their syllabus, so some of the stuff that I'm going to be discussing might not be quite so quite so relevant for you working in different environments. But hopefully, some of this will be useful and at least useful in an academic sense, if not in a practical sense. Um, I'm going to assume a certain level of knowledge, but if I'm wrong in my assumptions, then please do ask questions. I want to make sure that we're all kind of understanding what's going on here. They'll usually what I do is ask a few questions as we go and ask people to shout out in a kind of face-to-face scenario. I don't know how well that's going to work. If that doesn't work, I'll do a bit more talking. But if anybody is up for contributing, I would be most grateful. So this talk is about the assessment of the well-being of babies antenatally, but really the question that people ask is my baby okay? That's what people really want to know. And sometimes it's quite obvious that there's a problem, and sometimes in pregnancy it can be really quite difficult to establish whether there's a problem or not. Some things are much more subtle, and that's really where my lecture focuses. It's on those subtle things where we need to do a bit of thinking and a bit of investigating to try and work out what, if anything, is going on. So we're going to talk about how we assess the well-being of babies, the sort of resources that are available to us in the UK. I appreciate that you may not have all of these resources available to you in the settings where you train and work. We're going to talk about the sort of things that we're looking for, what tests we can do, the limitations of those tests a little bit. And I'm going to share with you some made-up cases, but very much based on things that we see regularly working in obstetrics in the UK. And most of these things will be fairly universal. So we do talk about some challenging topics in this lecture, stillbirth, miscarriage, and so on. So just to warn people that could be potentially an upsetting topic. This is not about the assessment of babies in labour. It's not about early pregnancy. It's not really about the well-being of pregnant women. It's about the well-being of the baby. But of course, those two things are very closely linked. It's not about managing trauma in pregnancy or emergencies and acute problems. And really what we're going to be talking about pertains to singleton pregnancies, not twins, not triplets, although there is some overlap there too. So this is one of my babies, about 2 years old when that picture was taken. And the question that I always ask at this point is my baby okay? Looking at that picture, what do you think? Does he look all right to you? Does anyone want to shout out some answers? Do you think he's okay in that picture?
He looks happy, so I guess yes.
Thank you for contributing. Yeah, he does. He looks all right, doesn't he? He's smiling. He's got food there. He's dressed up in his science goggles. He's stolen my watch. He's really happy. He's playing a game. And there's quite a lot of clues in that picture that he's absolutely fine. This was him on the day he was born. And he was okay when he was born. There were no problems. But if I ask the same question, is my baby okay in that picture? It becomes a little bit harder to tell, doesn't it? You get a few clues still. So you can see that there's a little bit of tone there. He's got his hand up by his face, so he's got some muscle tone. He looks quite well perfused. He's got a nice color to his skin. But you know, he doesn't have any feeding tubes, he doesn't have any oxygen, so there are clues, but that was a little bit harder to tell with a newborn baby. But when he was wrapped up inside the body of a human being, it was even harder to tell. That's a picture of my other son there, who was convinced that he was pregnant when my wife was expecting. But when a baby is in the uterus and you ask the question, is my baby okay? It is much, much harder to answer. You don't get any of those clues. There is one really important clue that you do get. What is that? Have a think about it. And if anybody thinks they know, then please shout out the answer. What is the one thing that will tell you if a baby is okay?
In the mother's body, it's probably the movement.
Thank you so much for contributing. I'm afraid I couldn't hear what you said.
I said that in uterus, it's probably the movement of the
The
baby.
movement, absolutely, yeah, absolutely. You're completely correct. It is potentially the only signal that a pregnant woman gets that her baby is okay, if she is otherwise well. And of course, if somebody suddenly has intense pain and bleeding, you're going to notice that there's a problem. But most of the time, um, the only indicator of fetal well-being is the movement of the baby. So this is worth thinking about a little bit. First thing that I like to talk about is, how do you define a fetal movement? Some of you may have had babies yourselves. You may know intuitively what it feels like. But if you've never been pregnant, it can be quite difficult to describe. If you had to write a definition for a guideline, it's not an easy thing to do. The RCOG, the Royal College of Obstetricians and Gynecologists in the UK, have given us a definition. Any discrete kick, swish, flutter, or roll. But that's about as useful as a chocolate teapot. It's not a helpful definition. We kind of know what we mean by the movement of a baby. That doesn't really help us. But I suppose if somebody said to you, I'm not feeling movements, I really don't know what I'm supposed to be feeling, can you describe it to me? Then maybe that would be useful. What counts as normal? Okay, so we've established what a movement is, but how often should they happen? How intense should they be? These are difficult questions to answer, but the question that's important is, how long do healthy babies go without moving? Babies sleep in the uterus just like we sleep, but they have a different sleep cycle. Babies sleep for about 40 or 50 minutes at a time. So if you get beyond that, you start to worry a little bit that perhaps there's a problem. But up to 40, 50 minutes, babies do sleep. They do have reduced movements. So that's quite normal. How intense should movements be? Well, they should get more intense as pregnancy goes on, but each pregnancy is different. Sometimes people will be worried because although they're feeling their baby move, it doesn't feel as strong as the last time that they were pregnant. There are all sorts of things that can account for that, which we're going to talk about a little bit. So, are you feeling your baby move? Is a binary question, yes or no. Yeah, you're feeling your baby move. Does that mean your baby's okay? We need to unpick this a little bit more. If we think about situations where babies' movements are reduced, we can break these into two broad categories. There are situations where the movements of the baby are actually reduced. And the most important cause of that is fetal death, fetal demise, so a stillbirth. If a baby has died in the uterus, it will stop moving. But the idea here is that there is potentially a prodrome where death is imminent, the baby is very, very sick, and it stops moving as a means of conserving energy before death occurs. And that's really important because maybe we could intervene and do something to prevent the death of that baby. There are some babies that never move. So it's a very different situation if somebody comes to you and says, I'm really worried about my baby's movements. My baby moves loads. This is a really, really active baby, but yesterday they stopped and I haven't felt them move since. That's a very worrying situation. A situation where a baby is never felt to have moved is quite different. It suggests different problems. And potentially, a baby that has never been felt to move could have some sort of neuromuscular problem. Then, of course, there are sedating drugs. We give people sedating drugs in pregnancy, especially if they need any sort of procedures, but also people use street drugs, recreational drugs, and those can have an impact. Alcohol can have an impact on the movement of a baby. So those are the situations where the movements are actually reduced. But then the more common scenario are situations where the perception of movement is reduced. So that could simply be that a person is distracted. If somebody has had a traumatic day, if they've been involved in an altercation, if they've been moving house, if one of their relatives is unwell, all sorts of major life events can happen to people whilst they're pregnant, and these are potentially distracting and could lead to the focus being away from those movements of the baby and onto other things. People talk about the position of the placenta being important. The way that we feel movements of babies is through the abdominal wall. That's where the nerves are. That's where we can sense the movement. So if the placenta is at the front of the uterus, between the baby and the wall of the uterus, potentially those movements will be dampened a little bit, and we may not feel them as strongly. That would explain the difference between the last baby moving really well and this baby moving a bit less, but it wouldn't explain a change in movements for this baby. So that situation where baby's been moving well until yesterday and then stopped, not explained by the position of the placenta. We would need to look a little bit more deeply. The presentation of the baby is important, or rather the position of the baby, because if you think about that placenta, the baby is facing away from the placenta and kicking in the direction where it's having more impact on the abdominal wall, it's likely that those movements will be more readily perceived. If the baby then changes position, becomes breech or rotates and starts kicking the placenta, then that might be perceived as a change of movements. Some people have suggested that the amount of amniotic fluid around the baby might have an impact, or the degree of obesity of the mother might have an impact, but those are controversial suggestions. But the key thing is sometimes the movements are actually reduced, and sometimes they are simply perceived to have been reduced. So does it matter? Yes, it does matter. If somebody is feeling good movements consistent with what they've felt throughout their pregnancy, that is reassuring. But it can be falsely reassuring. What that means is that movements of a baby are a sensitive sign, but they're not a specific sign. We know that very sick babies don't move very much. In the same way that if you become ill with influenza or COVID-19, you're really sick, you're probably going to get into bed and not move much for a couple of days. But we've all had days where we were just lazy, haven't we? We've all had days where we slept in, where we moved less than we ought to have done. It doesn't necessarily mean that you're very sick. But we're interested in this because where cases go badly, where stillbirth occurs, where there have been failings in care, and this has been highlighted through various reports and confidential inquiries in the UK, we know that reduced fetal movement and mismanagement of that situation is often implicated. We know that there's a relationship between the movements of babies and the risk of stillbirth, but there are limitations in research in that area, and I'm going to explain that to you in a bit more detail. And in the UK, this forms part of something called Saving Babies' Lives and the Maternity Incentive Scheme. So we're really not getting away from it in UK practice. I won't go into too much detail about that, but if anyone particularly wants to know about those aspects of UK healthcare, I'll be really happy to talk about it more. So when we're researching the relationship between reduced fetal movements and bad pregnancy outcomes like stillbirth, this is quite difficult. Most of the research that we have available to us is cohort studies and case control studies. So they're retrospective by and large. And we have well, first thing is there's a treatment paradox. So what that means is that we tend to intervene as obstetricians to prevent the outcomes that we're most interested in. We want to deliver that baby before the stillbirth occurs. So if we're interested in the relationship between stillbirth and reduced fetal movements, we might underestimate the effect of that relationship because we deliver those babies before they die and therefore reduce that outcome. Stillbirth is a rare outcome already without that treatment paradox, and very few studies are big enough to have adequate statistical power to look at stillbirth. So sometimes what researchers do is they use other markers. So something like low birth weight, it's a surrogate marker. We know that small babies are at risk. The size of the baby correlates with the size of the placenta and the function of the placenta, and babies where the placenta is really not working well are at risk of stillbirth. So we measure something on that pathway, but it's not the same thing. Being a low birth weight baby doesn't matter if you're perfectly healthy. What matters is if you are sick, if you have a brain injury or come close to it or need to go to the neonatal unit for a long time. These things matter. Being small, if you're well and small, isn't very relevant. The problem with retrospective research is there's a risk of recall bias. So if you ask people who have had a stillbirth, was there a reduction in the movement of your baby before the stillbirth occurred? They will invariably say yes. And part of the reason for that is because the moment that they will remember as the stillbirth is the moment when they were told that the baby has died. Maybe they had a scan and there was no heartbeat. Maybe the baby was born without a heartbeat. That is the moment they will remember, but that is not the moment when the baby died. The baby died at some point prior to that, maybe minutes, hours, days before that, at which point it will have stopped moving. And so there will have been a time where the baby did not move because it was dead already. That doesn't mean you had a potential window to intervene. So this relationship between reduced fetal movements and stillbirths is quite obvious. Dead babies don't move. But this is a particular problem when we're looking at research in this area. So it's heavily biased. The best evidence that we've got is from the AFFIRM trial. This is a big randomized control trial in the UK and Ireland, and it was more than 400,000 pregnancies enrolled in this trial. And what they did was they offered an intervention when people came in with reduced movements. And the intervention was a package of staff e-learning, information provided to pregnant women, a growth scan if they were worried about the movements of the baby. And if the baby was found to be small on that scan, then they delivered them early. And despite all of that, they did not reduce the incidence of stillbirth. And that tells you something. That tells you that the cases where there is an association between reduced movements and stillbirth are the ones that were too late to make a difference. And it tells you that the rest are not at risk of stillbirth, statistically, according to this study. So that's interesting. But reduced movement is still important. People worry about it a lot. We tell people in the UK they must monitor the movements of their baby and come and report to us if there are any changes. So we create a lot of anxiety around this. Okay, I want to have a think about this case. Now, normally what I would do is put this to the audience. I think the sound quality is a bit tricky, and so if anyone wants to shout out, please do so. Otherwise, I'm going to do a bit more of the talking for this one. So in this case, we've got a 34-week primip, so a woman having her first pregnancy, and she's been looked after by the midwife so far. So she's low risk. She hasn't needed to see the obstetricians at all. She's come to us because she's worried about the movements of her baby. And the question is, how would you approach this case? She's saying, is my baby okay? What are you going to do? Now, if you were given a case like this, if you're given any case in an exam, for example, or somebody puts you on the spot and says, how are you going to approach this case? Then you need a structure to that answer. And you could talk about an ABC approach. That would be one way to do it. Or you could talk about taking a history and doing an examination. Okay, so you're going to take a history. You're going to take a history of the presenting complaint. Now, we're talking about movement, so we want to know what has changed. But as part of that, we need to know what is normal for her. So if she says, look, I normally feel my baby move really strongly between 6 and 7 o'clock in the morning, and then I feel bits and bobs for the rest of the day. And it's been like that for my whole pregnancy. And so now you've established what's normal for her. If she says to you, well, look, there's been a bit of a change. I felt my baby move on this side most of the time, and now I'm feeling it here and it feels a bit lighter. That's a bit less worrying than if she says my baby's been really active and 2 days ago stopped moving and I haven't felt them move since. So we're starting to kind of pick apart the history of the presenting complaint there. Of course, you want to know if there's any associated symptoms, any other factors. Is she otherwise well? So you can ask some specific questions. Have you had any bleeding? Have you got any pain? Have you had any discharge? That sort of thing. And then your standard past medical history, obstetric history, drug history, allergies, etc., that you will be familiar with as medical students. You're going to need to do an examination. Now, it's worthwhile doing a thorough examination. Sometimes what happens when you're a specialty doctor is you get very focused in on your bit and you forget that you can listen to the heart and lungs and you can do a neurological assessment and so on. But what I'm going to focus on is examination of the pregnant abdomen. So my hope is that you are going to be able to hear the sound from this video. If I press play and you don't hear any sound, then please do let me know.
Hello, my name is Polly. I'm one of the medical students. Can I confirm your name and date of birth?
Yes, it's Kitty Simpson, 29th of March 1985.
Nice to meet you, Kitty. Today I've been asked to perform an examination of your pregnant abdomen. This will involve me having a look at your tummy, feeling your tummy and baby's position, also taking some measurements and listening into your baby's heartbeat.
So in the UK, and I imagine that this is probably true in most medical schools, but in UK medical schools, you get a lot of credit for doing those basic things, those introductions, washing your hands, checking patient identity, those sorts of things. And if you go on to do professional exams that are based in the UK, these are the sort of things that will be expected from you. So it's not obstetric specific, but it's just a little learning point that it's really worth getting those basic things right.
Is that okay?
Yes.
Do you have any pain today?
No.
You shouldn't have any pain on the examination, but some people can find it slightly uncomfortable. If at any point you find it too uncomfortable or you have any pain, let me know.
Okay.
Would you like to empty your bladder before we begin?
I'm okay, thank you.
So offering to empty your bladder is really important with obstetric examinations. It's quite a kind thing to do when you're going to be pressing on somebody's tummy anyway, because it can be pretty uncomfortable if you've got a very full bladder. But in pregnancy, the bladder can act like a balloon. As it fills, and people can be quite prone to overfilling of the bladder in pregnancy, but as the bladder becomes very full, what it does is it lifts the fetal head, or the presenting part of the baby, out of the pelvis. So one of the things that we're interested in when we're examining pregnant abdomens is how engaged is the presenting part? How deep is it within the pelvis? And if the bladder is super full, it falsely pushes that part out. So emptying the bladder is a really good tip if you want to assess how low that presenting part is, if you want to assess engagement.
Have you got any questions?
No.
Are you comfortable?
Yes.
To start with, I'm just going to have a look at your hands and feel your pulse.
Okay.
Now I just need you to expose your tummy for me, please.
Okay.
So one of the things it says here is about looking for surgical scars. So shape, fetal movement, surgical scars, and linea nigra. Surgical scars, we're interested in any surgical scars, of course. The exposure that we've got here of the abdomen will show us a midline laparotomy, but it won't show us a cesarean scar. The cesarean scar is lower than this patient's waistband. So if you want to see whether somebody has had cesareans, you're going to have to bring that waistband down a little bit further. The shape of the abdomen is interesting. Now, what you can see here is a third trimester pregnancy, but what you can sometimes tell quite a lot about the position of the baby from the shape of the abdomen. And babies that are occipito-posterior, so where the baby is facing forwards towards the front of the maternal abdomen, you often see a kind of double bump. You see a bit of a dip in the center of the abdomen and a bump above and a bump below. Just little clues that you can start to look for. People always tell medical students to look for the linea nigra, which of course is that dark line that you see down the center of the abdomen in pregnancy, that hyperpigmentation. It's completely irrelevant. It's a nice thing to comment on. It shows that you have learned about pregnancy and you know what it's called and you know the Latin name of it. So if you're in an exam, it makes you look clever. Totally irrelevant, in my opinion. So you start palpating the uterus, and here you can see that the examiner is using the side of her hand to feel the upper part of the uterus. So you get a sense of where the fundus is. Palpating the baby to determine the lie. Okay, so the lie of the baby is the axis of the baby with respect to the axis of the mother. So if the baby is head first or feet first, or breech, bottom first, then it's a longitudinal axis. But you could also have a transverse axis or an oblique axis. So the axis tells you what the lie tells you where the axis of the baby is, but it doesn't tell you if the baby's head first or feet first. So then what you need to do is look for the presenting part. So here you can see she's using a pincer grip, trying to palpate what is leading. And normally it's pretty obvious if there's a head there. This is a measurement of symphysiofundal height. I'm going to talk about this in a moment, but what she's doing there is measuring from the fixed point, which is the pubic symphysis, to the fundus. And roughly you expect the number of centimeters to equate to the number of weeks gestation. Listening to the fetal heart with a Pinard stethoscope. So the palpation is really important because what you need to do is work out which way the baby is facing. Is the baby facing away from you or towards you? And you listen over the anterior shoulder of the baby, kind of between the baby's shoulder blades, if you can tell where that is. And you should be able to hear the heartbeat.
And that's the end of the examination. I'll cover you up, okay?
Thank you.
All right. So get points for hand washing in an exam?
Today I examined Kitty, a 34-year-old woman. She's a para 0 at 39 weeks and 4 days in her first pregnancy. On inspection, the abdomen was gravid, appropriate for dates, and she had linear nigra visible. On palpation, the abdomen was soft and non-tender. The singleton fetus was longitudinal lie and cephalic presentation, and the head was engaged. To complete my examination, I would like to perform a blood pressure and urinalysis.
All right. So that's quite a nice example of how to do an examination, but also kind of how to present your findings and how to behave in an exam setting. Can I just check you can still see my screen? I'm going to assume you can, unless someone tells me you can't.
No, we don't.
You don't. Okay, thank you. Let's try sharing that again then. All right. I think you can see it now.
Yes.
Okay. So when you're taking a history and doing an examination, when you're a medical student and you're learning to do these things, the way things tend to happen is you'll have a list of questions that you know you've got to ask, and you'll go through your list. As you start to get a bit more experienced, what you'll do is start to think, what are the likely diagnoses that I want to rule in or rule out here? And you start to ask specific questions about it. Some things are quite easy to spot and you won't even have to ask any questions. So if somebody comes in with intense, constant abdominal pain and vaginal bleeding, that's probably a placental abruption until proven otherwise. And, you know, if you were going to write an exam question about this where placental abruption was the answer, you would say, you know, a woman comes in with constant abdominal pain. On palpation, the uterus is woody and tender and she's bleeding and there's fetal heart rate abnormalities. That's your classic placental abruption. You're not going to miss that. You know, yeah, you're going to run through a quick history and examination and look for other causes and make sure you've got the complete picture, but you've got your diagnosis as soon as she walks through the door. Similarly, eclampsia. If somebody comes in having an eclamptic fit, you're probably going to get that diagnosis pretty quickly. But there are some things that are a bit harder to spot. So things like a concealed abruption, subacute infection, that sort of thing. But the thing that is most interesting to me is placental insufficiency. Because when we think about stillbirth, placental insufficiency, I've said 30% here is placental insufficiency. It's probably substantially more than that, actually, because some placental insufficiency is difficult to diagnose. And at least 50% is unexplained. And a good chunk of that is probably placental insufficiency that's simply not been diagnosed. So we've got to think about how do we pick up those cases, the ones that are hard to spot, where potentially reduced fetal movement could be the only indicator that something is very wrong. If we want to prevent stillbirth, this is our high-level workflow, right? We've got a pathological process. In this case, we're talking about the placenta not working properly, and that can lead to death, but it takes time. And that gives us the opportunity to intervene and deliver the baby before death occurs. Once we deliver the baby, we remove the risk of stillbirth. You cannot have a stillbirth once the baby's been delivered. That doesn't mean you can't do harm. So, of course, if we delivered a baby at 24 weeks and 1 day gestation, that baby cannot be stillborn. We've removed the risk of stillbirth for that pregnancy. But of course, we're exposing that baby to all of the risks of premature birth, and there is a substantial risk of neonatal death in that situation. So we've got to bear that in mind. But the idea is that this process takes time. Now, if we're talking about a placental abruption, you've got very little time. Very little time. You're going to have to deliver the baby quickly before death occurs. But if we're talking about something like placental insufficiency, this is something that brews in the background over weeks to months. And if we can detect it, we can monitor it and we can plan delivery so that we don't, or so we minimize the amount of harm that we can cause by delivering early, but also remove that risk of stillbirth. So Hippocrates said, first do no harm. This is a really important concept because if we're too trigger happy with delivering babies early, we will cause harm. And this is some data that comes from the UK around the risk of death, neonatal death, at preterm gestations. So you can see that the earlier a baby is born, the greater the risk of death. So at 22 to 24 weeks, you're looking at about a 64% risk of death. And by the time you get to 37 weeks onwards, we're looking at kind of less than a percent. So really, we should avoid delivering these babies early unless we're really, really sure that they are likely to die if we don't. Death isn't the only important thing to think about. We should think about long-term health consequences. We know that premature babies don't do so well in a number of ways. The risk of disability is much higher in that group, even if they survive. One thing that's important to think about is the prevalence of special educational needs. So what this means is children who grow up needing more than a standard school can provide. They need additional support in order to get through their education. Now, this isn't the most important outcome. It is important to those people who are affected by it, of course it is, but it's arguably less important than death and severe disability. But the reason this is worth talking about is you can see that as the gestation increases, the risk of special educational needs reduces. And we tend to think of term as 37 weeks onwards in the UK. If you go to Japan, they'll tell you a slightly different number. But broadly, term is 37 weeks onwards. So you might say, well, once you get to 37 weeks, just deliver the babies because, you're removing the risk of stillbirth and their term. But you can see that once we get past 37 weeks, the longer you go, you still reduce the risk of having these special educational needs. So what that means is if we jump the gun and deliver all these babies at 37 weeks, we're still likely to be causing harm, even though they're term at that point. So we've got to balance the risk of causing harm by early delivery against the risk of harm if the pregnancy continues. And it's a dilemma. It's not easy to get this right. If we deliver them early, we reduce the risk of some very serious bad outcomes, but those outcomes are really rare. Stillbirth is rare. But we increase the risk of other adverse outcomes. And that's true for everybody, whether we get that risk assessment right or not. What that means is if you pick any arbitrary quality that is not associated with stillbirth, let's say people with green eyes, and you deliver them all at 37 weeks, you will reduce the incidence of stillbirth in people with green eyes because they can't have a stillbirth once the babies are born. But it doesn't mean that you're making things better overall. So it's all about it's all about finding the babies that do need early delivery. And that's really what I want to talk about now. So if we have a placenta that is not working properly, we've got placental dysfunction, placental insufficiency, that will eventually lead to reduced growth velocity. So we'll see a baby that is smaller than it ought to have been. It's very difficult to say how big it ought to have been. We don't really know, but a baby that is very small is likely not to have grown properly. A baby that started out in comparison to other babies being normal and is now smaller than other babies is likely to have a problem. We see Doppler changes. Now, Doppler is something we do with ultrasound. When we do scans of babies, we can use Doppler ultrasound to measure the flow of liquid, blood in this case, through blood vessels. So we talk about Dopplers, but what we really mean is the resistance to flow of blood through a vessel. We might then see changes in the heart rate pattern, the cardiotocogram, the CTG. That's a late sign. And then eventually death will occur if we don't do anything about it. And if we think about the time scale, we're looking at kind of months to weeks to days to hours. Okay, so we want to pick up the early signs and monitor. We don't want to find out there's a problem with hours until death. And reduced movements probably occur, if they're part of this process, they probably occur in the days to hours before death. So what we have to do when somebody comes to us and says, I'm worried about my baby's movements, is my baby okay? We've got to work backwards. Okay, we've got to start at the death end and work our way backwards. And I'm going to talk to you about how we do that in a setting with the resources to do so. So thinking about establishing whether a baby is alive. We can listen to the baby's heartbeat. That is a sure indicator that the baby's alive if you can hear the heartbeat. If you've got no equipment available to you, you put your hands on the abdomen, you might feel the baby moving. They're often very active. They kick you, that's very reassuring. But you can use the device on the left, which is a Pinard stethoscope. You saw a demonstration of how that was used in the video. Or you can use a handheld electronic ultrasound Doppler, which will play the noise of the baby's heartbeat. You use it in exactly the same way, except that instead of listening directly, you just put the transducer onto the abdomen in the right place, and it will play a sound. So that's really helpful. You can hear the heartbeat, and the nice thing about the handheld Doppler is everyone can hear the heartbeat. If the mother and family have come in really, really worried, and everyone hears that the baby has a heartbeat, that's a very reassuring thing for people to hear. We can also do an ultrasound scan. So if you are if you have ultrasound available to you, you have someone who knows how to use it, you could show them the fetal heart. And that's a lovely view of a fetal heart. And actually you can see the 4 chambers of the heart there beautifully. So show that to the mother and to the family, and that is a very reassuring thing to see. You can see that baby's moving as well. You can see it wriggling around. So sometimes it's quite nice to actually show the movements of the baby. So here's a baby. We just watch it for a minute. You can see it kicking. You can see it kicking. So if she says to you, or you ask at this point, can you feel those movements? And she says no. What that tells you is this isn't a problem with reduced movement. This is a problem with perception of movement. And that's reassuring. So you don't say you're wrong, but you say, well, look, I think what's going on here is your baby is moving, but for some reason you're not feeling it in the same way. And that is much less worrying. So you can use that to reassure. If she is feeling them, that's really good too, because babies that are at the end of that disease process don't suddenly start moving again. So if a baby has stopped moving because it's super, super sick, it won't be doing this. If you put the scanner on and you don't see a baby moving, that's much more concerning. Depends on the history. If she says, I haven't felt my baby move for 30 minutes, you say, well, that's quite normal. Babies sleep for 30 minutes at a time. But if she says, I haven't felt my baby move for 2 days and you don't see anything, then you would be increasingly concerned and you would want to do some more investigating. What we would do in Oxford and in the UK is a CTG. So this is a cardiotocogram. This monitors the baby's heart rate and plots it on a chart, and it monitors the intensity of the contractions. But that signal is calibrated, so it doesn't tell us anything about how strong those contractions are. Really, what it does is tells us about the frequency of contractions. And remember, we're talking about antenatal well-being of babies, not labor, so there shouldn't be much uterine activity, if any. So we can use CTGs in labor to monitor the well-being of babies, but we interpret them differently. I am only talking about non-labor CTGs. And what we're looking for are features of the heart rate pattern that are associated with hypoxia, with being low on oxygen. Because if the placenta is not working properly, then the blood is not oxygenating properly, and the baby can develop a hypoxic state. We can look at CTGs visually, or we can use a computer to do it. And I'm going to tell you a little bit about both of those. We're going to start with the visual assessment. So this is a CTG. What you do is, first of all, look at the average heart rate. So on this trace, what you can see is that the average heart rate is about 120, 125. You can see that there are some accelerations, so those areas marked with the pink arrows, where it increases from its baseline heart rate, and that's normal. That's a sign that the baby's moving and the heart rate is accelerating in correspondence to that. We want the average heart rate to be between about 110 and 160. It should be nice and stable. There shouldn't be a lot of fluctuation there. And it gets lower the more mature the baby gets. So it's useful to know what's normal for this baby. If you monitored a baby last week and it had a heart rate of 110, it would be a bit odd if it now has a heart rate of 140, even though that's within the normal range. But broadly, 110 to 160 would be considered normal. We want to look at the variability. So that's kind of the bandwidth here of the baseline. Ignoring those accelerations, we want to know how wiggly this line is. And it should be between 5 and 25 beats per minute. But because babies have these sleep cycles, it could be less than 5 for up to 50 minutes and still be very, very normal. And that change, that variability, reflects the the relationship between the sympathetic and parasympathetic nervous system, and so you get more variability as those parts of the nervous system develop as the baby matures. But this has got nice variability. It's a nice wiggly line. So here you can see another example. This is another normal trace. So here we've got a baseline of about 140. We've got nice accelerations, and we've got good variability. So that's a nice normal trace. We'd be quite happy to see that. This looks a bit different. Now, I know that the numbers haven't printed very well here, but what you can see is this looks much more like a flat line. It's not very wiggly. There's really reduced variability here. So we're not seeing that interplay between sympathetic and parasympathetic nervous system. We might be quite worried about this, but what you see here is that, in fact, this baby was just sleeping. If that pattern carried on, you would be really concerned. That would be a feature that's associated with hypoxia. But here you can see what's happened. The baby's woken up. Now the CTG has returned to normal. So as long as you don't have more than about 50 minutes of it looking flat like that, probably absolutely fine. This one looks a bit different. Now we've got a much higher baseline. It's around 180. So that's already tachycardic. We've got a baby that's working quite hard, and the variability is reduced. So that's a sign that's associated with hypoxia. So this is starting to look like maybe this is a baby that's low on oxygen. We'd be a bit more concerned here. What you've got here is a very different looking CTG. So the baseline is about 130, which is normal. So we don't have a tachycardic baby, but we don't have any variability there at all. This looks like a piece of spaghetti plonked onto the page. It's very thin. And you can see those little dips in the heart rate too. So we liked to see the accelerations, but these are decelerations, and these are very worrying. Decelerations can happen for a number of reasons, but what you can see here, if you look at the tocogram, which is the bottom line, you can see there is a little bit of uterine activity. These are not contractions, these are just mild tightenings, because this isn't someone who's in labor. But after each of those tightenings, you see a significant dip in the heart rate, and that is very concerning. What's happening here is as the myometrium contracts slightly, you get reduced blood flow to the placenta and therefore reduced oxygen delivery. Now, a healthy baby with a healthy placenta can tolerate that. A healthy baby with a healthy placenta can tolerate a full-blown contraction for 2 minutes without dropping its heart rate. So the fact that it's reacting in this way suggests that this baby doesn't have very much reserve. It's bordering on hypoxia, and when the myometrium contracts and the oxygen delivery is reduced, you're having a chemoreceptor-mediated reduction in heart rate in correspondence, and that takes a little bit of time to develop, which is why it's about a minute between the tightening of the uterus and the peak reduction in the heart rate. So this is a really worrying sign. This is a baby that needs delivery really soon. If you don't deliver a baby that's showing signs of hypoxia, eventually that baby will no longer be able to compensate. When that happens, the baby will go into this terminal bradycardia. So this is where the baby has completely lost all of its reserves, the heart rate drops and it cannot recover. And the only way that you're going to save that baby at this point is to deliver them and fill the lungs with oxygen. The placenta is not going to deliver oxygen to this baby anymore. So we can look at CTGs visually. It's a highly skilled task. Very experienced obstetricians will debate the findings of a CTG. Another way to do it is to use a computer. And we have a system in Oxford, it's used around the world. We developed it in Oxford called the Dawes-Redman system. And this is basically a statistical analysis of hundreds of thousands of CTGs, and we compare the trace that we're interested in against all of those others against criteria of normality. And it will tell you, has it met the criteria or not? So it's less subjective and it's much faster, and it's very good at picking up hypoxic babies. Most cases where the CTG doesn't meet the computer's criteria are still fine. But if it doesn't meet criteria, we then want to look at something called short-term variability. This is a number. So you get a printout of the CTG with a number, the short-term variability. You can't look at this manually. You can't visually assess short-term variability. Only the computer can do it. And the lower that number, the worse things are for that baby. So if a baby didn't meet criteria because there were no periods of high variation, let's say, sometimes babies do that. It's not the end of the world, as long as the short-term variability is okay. Short-term variability less than 4 is abnormal. Less than 3 is bad, and you probably need to deliver that baby as an emergency. And less than 2 is very bad and would be considered pre-terminal. So if you've got a normal CTG, or if the CTG meets the computer's criteria, it is very unlikely that there is end-stage hypoxia due to placental insufficiency. So normal CTG is a very reassuring thing. But there could still be other signs. You see where we are on that flow chart, we're still right up towards the right-hand side. So there could still be things going on towards the left. A CTG only tells you what's going on right now. It cannot predict an adverse outcome. So it cannot tell you that whether there's going to be an abruption or a cord accident. And it's designed to detect hypoxia, not to detect other pathology like infection. So we'll have a think about that in a moment too. So CTG has limitations, but it's a very, very useful tool to make sure we're not right at the end stage of that placental insufficiency process. Okay, so another case. Now we've got a 30-week para 1. She previously gave birth at 34 weeks, so we know she has a risk factor for giving birth early again. And she comes in by ambulance because she collapsed at home and gives a vague history that maybe her waters broke a week ago. She's not sure. There's just been a little bit of heavier discharge. She doesn't really know. She was busy, so she didn't come in. There was lots going on in her personal life. So she comes in and her temperature is 39 degrees Celsius. Her pulse is 120. She's hypotensive. She's tachypneic. She's got raised white cells and a lactate of 3. So she's septic. So when you see that collection of symptoms and someone says, what's the diagnosis? If this came up in an exam, she is septic. She needs antibiotics. And we need to identify the source of her sepsis. So you go through your history, you go through your examination, and what you find is that she's got a really tender uterus. And the amniotic fluid, the liquor that she's draining, is really very smelly. So we're starting to think, okay, this is a septic woman. We need to know the source. The source sounds like she's ruptured her membranes. The infection has got up into the uterus. She's got chorioamnionitis. So you do a CTG to assess the well-being of the baby, and it's normal. Baseline 160. So top end of normal, but she's a bit tachycardic too. Normal trace. So the question is my baby okay? Well, the baby's alive, the CTG is normal, but this baby is not okay. This is chorioamnionitis, and the baby needs to be delivered. So this was just included to highlight the importance of not relying solely on a CTG. We've got to look at the clinical context too. And the context here is someone who's very sick with chorio. The baby is in an infected environment. Nobody is okay in this situation. This woman needs delivery despite the CTG being normal. I'm going to talk about assessing growth and Doppler changes together, because the reality is that these are things that both come from a growth scan, an ultrasound scan of the baby. So we'll think about those together. Now, when we think about the growth of the baby, one thing that's very easy to do is measure the symphysia fundal height. You saw that in the video, and it's something that's worth being familiar with. It's a very rough assessment of how a baby is growing. Generally speaking, what you'd expect is the measurement of the bump in centimeters should equate to the number of weeks. So if somebody's 32 weeks, but their bump measures 28, well, maybe they're a bit small and maybe we should do some more investigation to make sure they're okay. But this is actually a really inaccurate way of assessing the growth of babies. It's only about 27% sensitive. One study said that it will detect about 14% of small babies. So it's really pretty rubbish. But it's very cheap. It's easy to do anywhere. All you need is a tape measure. So we need to be careful about over-interpretation of symphysia fundal height measurement. A normal symphysia fundal height does not mean no problem, but a small symphysia fundal height is probably worth investigating. The better way, if you have the resources to do it, is to do growth scans. And growth scans require somebody skilled in assessment of ultrasound. It's a limited resource. Even in a UK setting with National Health Service, ultrasound is a limited resource. And so we need to try and do it for those with risk factors for growth restriction, or if there's a new problem arising. So if somebody's come with new hypertension or something like that. So we've got to be selective about who we scan. We can think about who gets them. Well, we can't do them for everybody. It's a limited resource. So it's very difficult to scan everybody all the time. Also, every test you do has a risk of a false positive finding. So we might over-intervene. And we've heard a bit about the risks of intervening where it's not necessary. We could cause harm if we scan people where the a priori risk is low. I put wealthy people. This is me being quite cynical, because in countries like America, that is what happens. The wealthy buy antenatal care and get scanned all the time. And people without wealth cannot access that resource in the same way. So it's highly inequitable. But what we should try to do is find the people at greatest risk of having placental insufficiency and scan them. So we need to think about risk assessment. This is how we are advised to risk assess in the UK. This comes from the Saving Babies' Lives care bundle. And essentially it's a tick box risk assessment, and you tick whether you've got these binary risk factors, and depending which ones you've got, if any, it determines what schedule of ultrasound scans you should have. And this has some real value, because you could do an assessment like this on the back of an envelope. You don't need any complicated equipment. You don't need a supercomputer. Anyone could do this anywhere. You could do this in a setting with very little resources, if you had the resources to follow through with the scans. But this is actually a really problematic way of risk assessing, because it relies heavily on previous pregnancy outcomes, like previous low birth weight, for example, previous stillbirth. You can't score for those things if it's your first baby. But we know that people having their first baby are at greater risk of growth restriction and of adverse outcomes. So this is biased against that group. We're taking complex continuous variables like estimated weight or birth weight, and we're making them binary. The smaller a baby is, the greater the chance that it has a problem. But if we pick a cutoff, like the 10th centile, and we say, okay, less than the 10th centile, we'll call that small, more than the 10th centile, we won't. What about the 11th centile babies? Those babies are quite high risk, but they just haven't crossed the threshold. What about somebody who has had 3 babies and they were all on the 8th or 9th centile, and now this baby's on the 7th centile? Is that baby really at greater risk? That baby could well just be constitutionally small, and we're creating an anxiety, and we're intervening and potentially over-intervening and causing harm for something that could well be normal. I could go on for ages about why I think this needs to change, but I'll move on in the interests of time. So let's have a think about this. Here we've got a 34-week low-risk primip. So she doesn't have any risk factors. She won't be getting extra scans. She won't be having extra appointments with the obstetricians. But her midwife measures her bump, her symphysiofundal height, and it's a bit small. So she has a growth scan. And the scan report says this baby is normally grown. Great. So you think, good, well, we don't need to worry about that then. And the woman is asking, is my baby okay? Now, before we look at the scan findings, I want to emphasize a really important point. And this is the difference between 2 terms: SGA, small for gestational age, and fetal growth restriction. Sometimes it's called in utero growth restriction, but FGR. SGA is small. And usually what we mean by small is less than the 10th centile. We've drawn an arbitrary line in the sand and said, okay, less than the 10th, we'll call it small for gestational age. Anything above the 10th, we'll say it's fine. But that line is arbitrary. We could have picked the 5th, we could have picked the 20th. In contrast, fetal growth restriction is a baby that is not achieving its growth potential because the placenta is not working properly. And those babies are at risk of bad outcomes. And they need surveillance, and they potentially need early delivery. Most FGR babies will become SGA. They will fail to grow to the extent that they are less than the 10th centile. But some babies that are less than the 10th centile are just constitutionally small. They were always going to be a bit small, in the same way that some adults are a bit shorter than others. It doesn't mean they're sick, and we could harm those babies by intervening. So there's overlap between these 2 terms. We want to find the FGR babies, but what we're really looking for when we do a scan is often the SGA babies. Let's look at the scan. So we've measured the head, the biparietal diameter, the head circumference. We've measured the abdominal circumference. We've measured the length of the femur, and we've put that all into an equation, and it's given us an estimated weight. And the estimated weight is the 14th centile, which is why the sonographer has said this is a normal scan, because it's more than the 10th, right? Great, this all looks fine. Abdominal circumference is particularly important because that's one of the first to go off if a baby isn't growing properly. So this looks like a really reassuring set of results. It's a bit, not the biggest baby, but perfectly fine. But if we look back against a previous scan, this woman had a scan at 20 weeks too. And at 20 weeks, the estimated weight was on the 67th centile. So we've got a drop from the 67th to the 14th. A 53 centile point drop. That's quite significant. This is not a baby that's growing properly. So it's true in one sense to say this is a normal scan because the baby is over the 10th centile. And if we view it in isolation, it is normal. But if we view it in the context of how this baby has grown throughout the pregnancy, this is a reduction in growth. This is an FGR baby. It's also worth having a think about where these charts come from. So here we've plotted the weight of the baby on a very commonly used reference chart called the Hadlock charts. Now, these are used all over the world. They were developed by Frank Hadlock in the United States published in 1991, but on a cohort of women who were pregnant in the 1980s, about 400 white middle-class American women. So how relevant that population is to our population in Oxford or to your population where you work, probably not very relevant at all. There are other charts available like the intergrowth charts or the WHO charts. All of them have their strengths and limitations. And it is just worth thinking with any comparison against a reference chart, how was that chart created? Where did this data come from? Let's talk about Dopplers. So we can measure the blood flow through various vessels using ultrasound. Here are some that we do commonly. On the baby side, we can look at the umbilical artery. We look at something called the pulsatility index or the resistance index. That's the PI or the RI. Basically, we're just looking at how much resistance there is to flow through the vessel. We can look at the middle cerebral artery. We can look at the ratio between the two, and that gives us the cerebroplacental ratio. And we can look at the ductus venosus. I'm going to talk about all of these and explain them. On the maternal side, we can look at the uterine arteries, and that gives us a measure of risk. So increased resistance to flow through the uterine arteries helps us identify the babies that are at risk of developing preeclampsia and fetal growth restriction. The Dopplers that we do on the fetal side are about assessing the well-being of that baby. And it's very easy to get confused between the umbilical artery and the uterine artery in this context. So just remember the umbilical artery is an assessment of fetal well-being, but the uterine artery is maternal and it's a predictor of adverse outcomes. When we look at the umbilical artery, a pulsatility index more than the 95th centile is considered abnormal. So what that suggests is that there is resistance to flow through the cord. And one of the things that we talk about is, so you get a centile. So you'll say the pulsatility index is over the 95th centile. Then what we want to know is there end diastolic flow? So when blood flows through the cord, what should happen is in systole, there should be nice, strong flow. And then in diastole, there should still be some flow. And you can see that in the image on the left. So the peaks there are represent systole, and the troughs represent diastole. And we've got time along the x-axis and velocity along the y-axis. So even when the heart is relaxed, there's still flow through that cord. That's good. That's what it should be like. But if the placenta is really fibrosed and putting up resistance to flow, then what can happen is that you get flow through systole, but then in diastole, flow stops. And you see that in the center image. We call that absent end diastolic flow, and that's a bad sign. If things get even worse, the flow can actually reverse during diastole. So it flows forward during systole and then back a little bit during diastole if there's real resistance from the placenta. And absent or reverse end diastolic flow is an indication that that baby needs to come out pretty quickly. So we can look at the blood flow through the middle cerebral artery Doppler, gives us an assessment of what's going on in the brain. Now, babies that are in a hypoxic environment will do something very interesting. They will try to spare the brain. So what they do is they dilate their cerebral blood vessels to send more blood to the brain, and they constrict the vessels through the rest of their body to divert blood away from, for example, the liver, which is why that abdominal circumference measurement is often the first to go off. So if you see a baby that is sending more blood up to the brain, that baby is compensating for something. It may not be critical, but it's trying to spare its brain. So in the umbilical artery, more than the 95th centile is abnormal, but in the brain, we're looking at the opposite. If there is reduced resistance to flow, that is abnormal. So less than the 5th centile is what we're looking for. We can look at the ratio between the two because it's sometimes not as simple as saying that, you know, it's the umbilical artery is raised, the middle cerebral artery is reduced. The ratio is helpful. And a ratio less than 1 is not a good sign. That's a baby that's compensating. But we could plot the ratio on a reference chart too. There are reference charts available. But just as a general rule of thumb, a CPR less than 1 is not a good thing. Occasionally, what we'll do is look at the ductus venosus. Now, this is something that we use in very preterm babies, where we know that there is a problem with growth, and we know that there's a problem with other Dopplers, and we're waiting for the baby to be really, really sick before we deliver because they're really, really preterm and the risk is high. This isn't something that we wait for in term babies. It's not useful in babies in the 3rd trimester, but in very preterm babies, it's helpful. So the ductus venosus is, you will remember, I'm sure, from your anatomy, is a fetal shunt. It bypasses the liver and it becomes the ligamentum venosum once the baby is born. When you have a hypoxic baby, there's an increase in systemic vascular resistance because that baby is trying to divert blood away up to the brain. You get an increased pressure gradient in the right atrium. It's quite difficult to measure that on ultrasound in the heart itself. You get worse venous diastolic flow because of that reduced return to the right atrium. And we need a nice little vessel close by where we can measure what's going on. And that is where the ductus venosus comes in. So this is a venous Doppler rather than an arterial Doppler. So we see a different sort of pattern. And with venous waveforms, one of the things we look for is the A wave, and you can see it on those figures at the bottom there. So you want a positive A wave, like you can see in the picture on the left. And if you get an absent A wave, like you can see in the picture to the right, that is a very bad sign, and that baby needs to be born immediately. So if we've got a really critical baby that we're waiting to fall off its perch and potentially need to deliver, we will deliver that baby when the A wave is lost or when the CTG becomes abnormal. Those would be our criteria for delivery in preterm gestations. So, uterine artery Doppler, remember, not about assessment of the well-being of babies, but in fact about risk prediction. If there's increased resistance, so if the pulsatility index is over the 95th centile, that is abnormal. And that tells us that there's a higher risk of there being a problem with growth or preeclampsia later on in the pregnancy. So we come to the final case. Now we've got a 36-week pregnant woman. She comes for her routine 3rd trimester growth scan. So in Oxford, we scan everybody at 36 weeks. We're unusual in doing that. So she's been well up until this point. She hasn't been worried, happy with baby's movements, happy with everything else. But we do the scan. This baby is tiny. It's less than the 1st centile. Now, I said, you know, not all babies less than the 10th centile are sick, but a baby that's less than the 1st centile is very, very small. The smaller a baby is, the more likely there is a problem, and the less likely this is just constitutional smallness. So we look for other signs of growth restriction. We look at the umbilical artery. The pulsatility index is over the 95th centile. So that's abnormal. There's resistance to flow into the placenta. But the end diastolic flow is positive, and that's a reassuring finding. We look at the flow in the brain through the middle cerebral artery, and we've got evidence of redistribution because the middle cerebral artery is less than the 5th centile. So we are seeing a baby that is trying to compensate. We've got a teeny tiny baby with resistance to flow through the umbilical cord and signs of redistribution. And we look at the ratio, the cerebroplacental ratio, and it's less than 1. So that supports the idea that this baby is trying to compensate. It's redistributing its blood flow. We put the baby on the CTG, and it does not meet the computer's criteria. If the short-term variability is 3.2, remember less than 4 is abnormal, but less than 3 is really bad. So 3.2 could be worse, but we're 36 weeks. We have little to gain and we have a lot to lose. So we would deliver this baby. So to conclude then, we've talked a lot about fetal movements, which are a useful indicator of fetal well-being. Most people with reduced movements do not have an unwell baby, but occasionally, very occasionally, reduced movements is the only sign that something is wrong, such as placental insufficiency and fetal growth restriction. We can use CTGs, we can use growth scans, we can use Dopplers, all to assess the well-being of babies, but none of these are perfect. They've all got their pros and cons. And there is no one test, or indeed no combination of tests, which can accurately predict bad outcomes, including stillbirth. So we have to take a holistic approach, and we have to remember the basics. We've got to focus on those, taking a good history and on doing a thorough examination before we get to these investigations. And that is the end of the lecture, and I will be very happy to take any questions. I'm very happy to take questions about the topic of the lecture. If you have questions relating to other aspects of obstetrics, then you are very welcome to ask those as well, and I will do my best to give you a reasonable answer. I can see that